to all the concerned officers and the nodal officers from all the premier institutes in the country. Today is really exciting. The topic that is the adverse drug reaction, which we all are very familiar into that, and the reporting and monitoring, which is essential, very essential, is almost all the patients are this taking drug, and in many cases, this adverse drug reaction is also another this impacting the patient's safety concerns, which can lead to a spectrum of health effects, even leading to death also. So on this day today, we are having this Dr. Vikas Ranjan Meher, the section expert, additional professors from the AIMS Bhubaneswar Department of Pharmacology. So it is, I would like to, call upon this Dr. L. Swasticharan, additional DDG, who is leading this program, this patient safety under the Ministry of Health and Family Welfare, to give some few words, so that and our this session expert then can continue. Over to Dr. Swasti, sir.
Thank you, Dr. Rameshwar. Greetings from the Patient Safety Secretariat to all AIMS Patient Safety Nodal Officers, faculty from medical colleges, hospitals, and residents, nurses, and other healthcare professionals who have joined us online today. We are really pleased to announce the fourth webinar of the National Capacity Building Program on patient safety, focusing on one particular important topic, which is adverse drug reactions, or ADR, reporting and monitoring. This webinar is a part of our annual webinar series, which aims to sensitize healthcare professionals across tertiary care institutions, including AIMS, PGI, JIPMER, and other medical colleges nationwide. In the past, I must also remind you that we have had various webinars on various topics of patient safety areas, and this crucial area we have picked up today because of popular demand. This session will highlight a critical yet unreported area of patient safety: the proactive identification, reporting, and monitoring of ADRs. Adverse drug reactions, friends, are a very significant cause of patient harm, contributing to prolonged hospital stays, increased healthcare costs, and in severe cases, mortality. Addressing ADR, therefore, is essential to ensuring safer use of medications and improving patient outcomes. Today, we are very happy to have amongst us Dr. Vikas Ranjan Meher, additional professor from the Department of Pharmacology, All India Institute of Medical Science, Bhubaneswar, as the expert speaker on this session. Dr. Meher will provide highlights and insights into strategies for effective ADR reporting, overcoming barriers to reporting, and lessons from successful programs that have been significantly shown to reduce medication-related harms. Friends, patient safety is not a program-driven initiative. Rather, it should be a culture in all our healthcare delivery systems. With this, I welcome Dr. Meher and also welcome each one of you. Let's have a very exciting session and learn and build into the culture of patient safety in India. Thank you very much.
Over to Dr. Vikas.
Okay, sir.
Oh, Dr. Vikas, I think you can start your session.
Good afternoon. Am I audible?
Yes, audible, Dr. Vikas.
And is the screen visible clearly?
Yes, yes.
Okay, thank you, sir. I thank this Patient Safety Secretariat. I express my gratitude for providing me this opportunity to present adverse drug reaction reporting and monitoring. I also welcome all the participants over here. So today we'll talk about and we'll discuss and know something about the adverse drug reaction reporting and monitoring. As Sir has already introduced, this is one of the most important topic as far as patient safety is concerned. So let's begin. So already we know as a medical expert, as a healthcare professional, that drug therapy is an integral component of the healthcare delivery system. It's very difficult to imagine effective healthcare delivery system without the use of medicine. But medicine or a drug has some problem that is known as drug therapy problem. And it is any unwanted incidents related to medication therapy. And it has been categorized broadly into seven major classes, like unnecessary drug therapy. When we are using excessive medication, then it is known as unnecessary drug therapy. Need additional drug therapy means we are giving inadequate medication. A wrong drug therapy, like we are giving a hypertensive patient, we are giving an antibiotic, then obviously it is a wrong drug therapy. Dose is too low. If we are not giving adequate dose, then it could lead to therapeutic failure. Like that, if you give high dose, then it could lead to toxicity. Then adverse drug reaction, which is the topic for the day, and non-compliance and non-adherence. That means if patient is not taking the drug as per the advice of the treating physician or doctor, then all this will hamper the optimal this benefit of drug therapy. So today I'll speak about the adverse drug reaction. So we should know what is adverse drug reaction. And when we talk about the adverse drug reaction, most often we come across with another term that is adverse event. So what is the difference between an adverse drug reaction and adverse event? So, so adverse drug reaction is nothing but unintended noxious response to a drug which occur at doses normally used in men for either prophylaxis, diagnosis, or therapy of the disease or for the modification of the physiological function. This is the definition given by WHO. Then what are the adverse events? Adverse events is defined as any untoward medical occurrence which occur during the time of treatment. Then what is the basic difference between these two? The difference between two is that adverse drug reaction has a causal relationship with the medicine, whereas adverse event doesn't necessarily have a causal relationship. So in the further slide, we'll discuss or we'll know about what is this causal relationship and how will we establish the causal relationship. So we should now remember that the basic difference between adverse drug reaction and adverse event is that in the adverse drug reaction there is a causal relationship occur, whereas for the adverse event there might not be any causal relationship with the suspected medicine. So then what are the different types of adverse reactions? Adverse reaction can be classified into different categories like type A or augmented, type B, type C, type D, type E, type F. Mostly these type A and type B are common. So due to lack of the time, we'll discuss a little bit only about the type A and type B. We should know what is this type A reaction, what is this type B reaction. So type A reaction is also known as augmented reactions. That means these are the reactions which occur and when we increase the dose of a drug, it's kind of an extension of the pharmacological effect of medicines. And so, because it is the extension of the pharmacological effect of that medicine, we can predict that okay, this the reaction can occur if we increase the dose. So that is dose dependent. Type A reaction is dose dependent, occurs when we increase the dose. So how you can treat this? We can treat this by reducing the dose, or we can also discontinue the medicine. And one of the common example of type A reaction is hypoglycemia by sulfonylurea. Sulfonylurea, as we know, is a oral hypoglycemic drugs used for diabetes mellitus. So the pharmacological effect of it, we know that it causes decrease in blood sugar. So if we increase or if we give a increased dose of sulfonylurea, then there is chance that patient might develop hypoglycemia. So that can be predictable, that can be known. Whereas type B is known as bizarre reaction. That means it is unpredictable and it doesn't have any relationship with the dose or pharmacological action of the medicine. It can occur at any dose, and it may occur in some individual who is taking the drug, but it may not occur in some individual who is also taking that drug. That's why it is known as unpredictable, bizarre, and it, although it is uncommon, not that common if we compare with the type A reaction. Type A reaction incidence is more, but type B incidence is less, but it is often severe and lead to death. It causes high mortality. So what should we do? We should uh, treat this, or we should manage this by stopping this medicine, stopping the medicine which has caused this reaction. And what else we can do? We can do that, we can advise the patient to not to take this medicine in future. And one of the common example we know in the pharmacology is that hypersensitivity reaction or anaphylactic reaction to the penicillin. So some penicillin can be given for this syphilis and other infectious diseases. Some patients who are predisposed due to some unknown reason, maybe genetic or maybe due to other reason, they develop hypersensitivity or severe anaphylactic reactions, sometimes causing death when they take the penicillin. But some patients may not develop this type of anaphylactic reaction. So once a patient develop anaphylactic reactions, we have to immediately discontinue giving penicillin, and in the future also he should not use or he should not take penicillin at any cost. Another example is aplastic anemia caused by chloramphenicol. Then another thing is the serious ADR. What is serious ADR? Because when we are discussing about the adverse drug reaction, we should know some of this terminology. When we discuss about the pharmacovigilance, or when we report this ADR, or upon this term comes. So serious adverse drug reaction is defined as any untoward medical occurrence that occur at any dose which result in death. First is whether if it causes death to that particular patient, or if it is life-threatening, or if it requires inpatient hospitalization or prolongs the duration of the hospitalization after taking the drug, or if it results in persistent disability or incapacity, or it causes any congenital anomaly. Then all these, if a drug causes any all these things, all these adverse reactions are considered as serious adverse drug reaction. So these five things, five types of different reaction we should know, which is usually known as serious adverse drug reaction. Then another things or another terms comes, that is severity or severe adverse drug reaction. One is serious adverse drug reaction, another is severe adverse drug reaction. And we have seen during this reporting or during the pharmacovigilance program that most often we comes to confuse with this serious as well as severe. But severe means it is the severity, intensity of a particular conditions, and it may not always lead to seriousness. So we have to correlate it. I'll give you one example, and there is a modified Hartwig's criteria. According to that, severity has been classified or categorized into three categories: mild, moderate, and severe. Like I can give you one example: headache. Headache can be severe, but it may not be serious always. If there is a functional headache, and if it has been a very severe functional headache, it might not be a serious ADR. But sometimes if there is an underlying pathology, something like something else, then we could be consider it as serious ADR. So always remember that severity and seriousness is not synonymous. So this is according to the modified Hartwig's criteria. As I told you, it has been categorized. Severity of the adverse reaction has been classified into three categories: mild, moderate, and severe. And there is this 1 2 is usually mild, three, the grade 3 and 4 are usually the moderate, and beyond grade 4 or step 4, all these are the severe. Like that means, one example I'll give you: an ADR has occurred, but we don't have to change the treatment of that suspected drugs. Or if ADR has occurred which required treatment, and with the suspected drug we held, discontinued, or otherwise changed, but no antidote or no other treatment is required for that particular adverse drug reaction, and it also doesn't lead to increase in length of stay. That means we can consider that okay, this ADR is mild. Similarly, if when we can say it is moderate, if ADR require a treatment, suspected drug to be held or discontinued, and an antidote or other treatment is required. We need an antidote or we need a specific treatment for that specific adverse drug reaction. Then we can call it is mild and grade 3 or step 3 variety because there is no increase in length of stay. Like that, at any level, that means 1, 2, 3 has occurred, but it increases the length of the stay in hospital by at least 1 day, or if ADR itself was the reason for the admission in hospital, then we can say that yeah, okay, this is the moderate variety, but grade 4. Then beyond that means if it requires medical care or it causes permanent harm to patients or indirectly linked to the death, then we can call this a severe ADR. So there sometimes it depends upon the wisdom and experience of those who are there in that ADR expert, that whether okay this severe ADR can also be considered as serious. That depends on the clinical judgment and experience. So then, because we are talking about ADR, there is a pharmacovigilance program going on in our country as well as in other country. So we should know why ADR is a big problem. This is the primum non nocere is the, as we know, this is the basic tenet of the medical care. That means do no harm. And any patient or patient's relative, they come to the hospital or they come to the physician with high hope that they can be get cured of the disease, they can be free from their suffering. So obviously our first job is to we don't induce. If we are not able to, due to some reason, if we are not able to cure any disease for some obvious reason, maybe if it is an incurable disease or something else, we should not induce any harm to that patient. What this ADR is doing. If we see the statistics around, there are different studies which has been conducted across the globe, which they have found out or observed that ADR increases the morbidity. ADR increases the hospital stay. ADR also causes mortality. In fact, there are statistics that ADR is responsible for 5 to 20% of the hospital admission around the globe, depending upon the which country we are doing the study. It is the sixth most common cause of this hospital admission, and it also causes significant death. It also causes a staggering what increases the healthcare cost severely. And last but not the least, it also breaks the trust, which usually is the most important or pillar of this healthcare delivery system. So it breaks the trust between the patient and the doctor, because patient has come to us with the high hope that I will get cure of my suffering or my disease, but rather than curing or what we are giving some preventable uh, infections, which has occurred due to the medicines or due to the drugs which we have prescribed to him. So what happens? So it will simply break the trust. Okay, this doctor has given me some medicine and it has caused harm, and because of that, I am again suffering more than that, more than the disease. So in the history, if we see the medical history, more or less, we are aware that there are leading some of the disaster had happened because of this adverse reaction, now we can say. And one of the most common or one of the most popular one, the thalidomide disaster, which is more or less we are aware about. So thalidomide disaster, with thalidomide, one of the drugs which was given or prescribed to the pregnant women for the treatment of this nausea and vomiting, morning sickness. And what happened? It caused phocomelia in the newborn. Then there is another diethyl stilbestrol story, which is a very tragic story, where this diethyl stilbestrol steroid was given to the mother. And what happened? That the progeny or the female progeny of that mother in the latter part of the life, her life, they developed this carcinoma, vaginal carcinoma. Then sulfanilamide. Sulfanilamide was one of the antibiotic very commonly used in the early 60s for the treatment of streptococcal infection. It was one of the most popular drug, and it was available in powder and tablet form. Then the some pharmaceutical company, they tried to change it to the change its dosage form. They wanted to make it to a liquid form. Elixir sulfanilamide they made, and what they did, they mixed diethyl glycol, which is a alcohol type of alcohol. They mixed, but they don't know, or they have no data regarding the safety of the diethyl glycol. And when they mix this sulfanilamide and diethyl glycol together and prepared this syrup, this liquid form, then it caused death in many individuals. So these are some of the stories which is a like kind of a dark spot in the medical history. And because of all these uh, sad events, drug regulation was made very stringent. Previously, drug regulation, drug development, and drug regulation was not that strict. But because of all these untoward event, all this sad story, then U.S. Congress they were modified the law, and then strict rules and regulation regarding the drug development and regulation come from there. This U.S. FDA, Drug and Cosmetic Act, also became very stringent. And many drugs have been, there are plenty of examples. There are many examples where the different drugs have been withdrawn from the market because they cause different type of adverse drug reaction. And many of those adverse drug reactions were fatal adverse drug reaction. We can see large number of examples, whether it is say this valdecoxib or cisapride or ropecoxib, torpenamide. So there are different examples we'll see uh, in the literature. And every year actually few of the drugs they usually been withdrawn by different regulatory agency, whether it is US FDA or in our country also, many drugs due to the different adverse drug reaction they are causing, and because of that they usually gets withdrawn from the market. So then how this adverse drug reaction can be prevented? Can it be preventable? As already I said that it can be prevented. So definitely most of the adverse drug reaction can be prevented if we timely recognize the symptoms. If we know that, okay, this could, if we suspect that this could be adverse drug reaction and we stop intake of the drug or we discontinue the drug, then it could be stopped. But how could we recognize the symptoms? If we can recognize the symptoms, if we have the required knowledge and skill, if we know about that pharmaceutical product, if we know about the type of adverse drug reaction and how to report this and other aspects of adverse drug reactions, and a little bit of pharmacological knowledge and about the disease for which we have prescribed that particular drug, if we have a required knowledge and also the skill, then we can prevent it. And before doing anything, what happens if we have given a drug, and if some patient has developed a adverse drug reaction, our first job is to appropriately manage that patient. So you have to appropriately manage that patient. And last but not the least, we should report it to the uh, there are different avenues that we'll discuss how to report. So we definitely report, because if we report, then further other patients will not develop that kind of report. And how they will not develop this report, that we'll discuss little later. So definitely I can say that most of the ADR, if it not all, then most of the ADR can be prevented if you have a required skill, and if we timely recognize this and appropriately manage and report it to the either to a ADR monitoring center or report to the concerned authority. So then now next comes the ADR monitoring. What do we understand by ADR monitoring? ADR monitoring is nothing but a process of continuous monitoring of an undesirable effect suspected to be associated with the use of a drug or a medicinal product. So we have to, or we need to continuously monitor the undesirable effect of that suspected drugs. And what is the, or what are the objectives of this ADR monitoring? Why we have to monitor these adverse drug reactions? First is to detect the nature and frequency of adverse drug reactions, so that periodically we can review whether it's what type of adverse drug reaction, whether it is severe, safe, unsafe, and why we have to need this. so that we can disseminate this information or we can share this information with the regulatory authority, with the treating physician, with the public health program, so that again it will, that means to the, we can share it with the different stakeholders, so that ultimately what will happen if we, a regulatory agency will take the necessary step, means that we might be, there will be in the package insert that necessary information will come or instruction will become, or if there is a severe fatal reaction, there is enough and there is enough signal, then that might actually, that drug might be withdrawn from the market. If we share this information with the treating physician or doctors or medical professional, then they will be very careful while giving this drug. They will have this safety and safety analysis of that drug. And another is to, we also, another objective is to, we need to identify the risk factors that predispose, induce, or influence the development, incidence, and severity of adverse drug reaction in population. Because a particular drug may be safe for a particular group of patients, but it may not be safe for the children, or it may not be safe for the old age population, or it may not be safe in pregnant women. So in those particular vulnerable population, that means we need to identify all those risk factors. Or a drug may be causing a specific adverse drug reaction in a specific race, particular either maybe in Asian population or it may be in black population, but it is not causing in any other group. So all those risk factor we need to identify. Then there is also, if we are taking this drug with some other concomitant drugs, there is drug-drug interaction is happening and it is leading to either toxicity or it is leading to therapeutic failure. So that kind of risk factor also we need to identify. Okay, then another is the concomitant disease. Okay, this drug is okay in normal person, not causing any adverse effects or reaction, but it might be causing adverse drug reaction if we prescribe this drug to a hypertensive patient or to a diabetic patient or to any other patient. So we need to identify all these risk factor which predispose or induce the development or also increase the severity of the adverse drug reaction. So we need to identify risk factors so that this drug adverse drug reaction will not occur in those particular population. That means that can be prevented. So what are the benefits of ADR monitoring? ADR monitoring provides information about the quality and safety of pharmaceutical product. It will give a fair amount of idea that whether this pharmaceutical product, particularly which has been newly got the approval from the regulatory agency, whether it is fairly safe overall or in any particular population. It assesses the safety of the drug therapy. Then it helps in measuring the ADR incidence of that particular drugs. Then it prevents the predictable adverse effect, type A adverse effect, because these are predictable. If we continuously monitor, then okay, these type of patients are getting this type of adverse reaction with this particular drug, then we will try to avoid using that drugs in that particular population. Then it creates awareness regarding the ADR. It creates awareness regarding ADR among the different stakeholders. And who are the stakeholders? Stakeholders are the patients or the consumers. Stakeholders are the different healthcare professional, doctor who is treating the, or who is prescribing the medicine, or other healthcare professional like nurses. Also, it also creates awareness. Or it passes the information to the drug regulatory authority, and they will usually take the necessary step to prevent that adverse drug reaction. So what are the data source from where we'll get this information about the adverse drug reaction of a particular drugs? So data source can be a solicited source or it can be a unsolicited source. Solicited source means here actively we are seeking the report. Unsolicited report means from it's kind of we are not actively seeking. It is available and we are getting the information. So solicited report can be generated like if we are doing a clinical trial and want to know the efficacy and safety of a particular drugs in particular population, there we can generate the safety data. It can be either carried out usually by the pharmaceutical company or marketing authorization holder, or it can be an investigator initiated trial. It can also be done by carrying out the non-interventional study. In a particular population, we are giving those who are taking the drug, we are for a particular time, we are following those patient or those population and seeing whether this drug is causing any adverse, any particular type of reaction or not. Periodic safety update report that we'll discuss little later. It has to be periodically, it has to be submitted by the pharmaceutical company or marketing authorization holder of the particular drugs to the regulatory agency regarding the safety of this different medicine, particularly after they get the approval. That means all those phase 4. Then we could also get the solicited report which is there in the different registry. There are different registry, whether it is a disease registry or whether it is a drug registry, whether if it is a disease registry, any cancer registry is there, and patients there are taking a particular type of cancer patient, they are taking a particular cancer anti-cancer drugs, and after taking that anti-cancer drug, they are developing some adverse effect. From there also we can come to a conclusion. An unsolicited report. Unsolicited report means someone, a physician has prescribed a particular medicine to his patient, and after few days, that patient came to him and said, the doctor, after taking the medicine, I have developed this thing has been occurred to me. Then that doctor usually will report it to either as a case report in any journal, or he will mention in some scientific forum. So that is kind of a spontaneous reporting or a literature report, or it has been mentioned by either a consumer or a medical healthcare professional that okay, someone has developed this kind of adverse drug, this kind of reaction or this kind of sign and symptoms probably after taking this drug. He has posted it in the digital media or social media. From there also we can have some idea that okay, this drug might be developing. And always I am saying this is the suspected. It is not confirmed, because till now if we are not doing any causality assessment, then we always say this is suspected adverse drug reaction. So these are the source of unsolicited report. Then what are the steps of ADR monitoring? How we can monitor this ADR? The first step is we need to identify the ADR. We need to identify the adverse drug reaction. And this adverse drug reaction can be identified either in the pre-marketing phase, that means in the clinical trial phase, or in case of post-marketing, after the drug has been marketed and has come to the market and now used by the different consumers or different patients, that time also we can identify. So first thing is we need to identify the ADR. Then next thing is the causality assessment. That means assessing the causality between the drug and suspected reaction. So adverse drug reaction, in the definition only I told you that how this adverse drug reaction are different from the adverse event. There is a whether there is a causality or assessment has been done. After assessing the causality, we can come to a conclusion. Okay, this drug has caused this or not caused this. So, and there are also different methodology for that. So after identifying the ADR, we need to do the causality assessment. So assessing the causality. Then according to the finding of that causality assessment, we need to document this ADR in the patient's medical record. Suppose someone has, like, common example is someone has taken a medicine like penicillin and developed anaphylactic reaction. So we need to mention it in his report, in his medical record, that okay, this patient is susceptible for the hypersensitivity reaction of penicillin, so that in the future any other medical professional or physician, when he is treating that and when he look this his medical record, will not prescribe him that this penicillin. Then the last but not the least is reporting of this ADR to the pharmacovigilance center or regulatory authority. We need to report all this ADR to prevent that, or to so that there will be that data will be gathered, and if there is a signal, then signal will be generated and further course of action can be taken by the regulatory authority. Then what are the limitation of the pre-marketing clinical trial? Because most of the this reporting is the post-marketing reporting. Because adverse drug, because as I told you, identify the ADR. So as we know little bit about this drug trial, nowadays drug trial is a very stringent process, and there are different phases of drug trial. This animal study occur, then after that phase 1, phase 2, phase 3. And these are very stringent process. And obviously in there also we are seeing the toxicity of the drugs. We are identifying its adverse effect. Then what's the need of then this post marketing safety analysis? Because there are some limitations of the pre-marketing clinical trials. Because pre-marketing clinical trial is always conducted in a controlled environment. A small, very small population are usually involved in the clinical trial because of the different constraint, and it is carried out for a small duration of the time, or less it will increase the overall cost. It usually conducted in the selected participants. We don't use all type of participants in the clinical trial. We use, again, we use this patient, we conduct clinical trial only in certain group of patients. Those who, and those who are taking a less number of drugs, only maybe our this investigational drug, or maybe some other drugs. But when a drug after gets after it get the approval from the regulatory agency, and now that pharmaceutical company has market and drug has reached to the market, so now the drug has reached to the real world scenario, and there this drug can be used in a large number of population, used in a diverse population, used in patient who are having a concomitant disease like maybe hypertension, diabetes, maybe other diseases. Patient might be taking more than one drug, and that time what happened, because in the clinical trial these things were not there. So, like why I give you one example. Suppose a adverse event is very rare adverse event, but it is very severe and fatal. It is causing death, and it can be only identified in 1 in 20,000 population, or 1 in 10,000 population. But in the clinical trial phases, we are not taking that number of participants. So obviously, we had missed that fatal reaction in the clinical trial. And suppose a adverse drug reaction is occurring after long interval, or after a patient is taking the drug for a long period of time, so that we cannot identify in the clinical trial phases, because clinical trial is usually conducted for a very limited amount of time, or else it will increase the overall cost. And because if it will increase the overall cost, then medicine will become eventually unaffordable. So these are the limitation of the pre-marketing clinical trial. That's why we do not, or we do not able to identify all type of adverse drug reaction during the clinical trial phases. That's why post-marketing surveillance is very essential. Post-marketing surveillance means after the drug has come to the market, after the drug has got the approval from the regulatory agency, and now this is being used by many patients. So, what are the different sources? Again, anecdotal reporting. One doctor has seen a patient, and he saw some reaction, or some sign and symptom is occurring in that particular patient after taking that drug. So this, and he has reported somewhere in a, maybe in a conference, or maybe have told to his peers or colleague. So this is kind of anecdotal reporting, or it can be done by intensive monitoring study, as already I told you, by particularly either could be a non-interventional study, or could be by a interventional study. And it could, a large number of data also is generated by spontaneous reporting system, which is all about the pharmacovigilance. And there are also other studies like meta-analysis, etc. From all these sources, have we can get the this information about the adverse drug reactions. So another thing, once we get this or identify at the adverse drug reaction, next, as I said, is the causality assessment. That means whether a drug is responsible or not responsible for that particular drug reaction, that can be only established by causality assessment. And there are different methods of causality assessment. WHO, Ursula monitoring, UMC causality assessment. There are some this categorized into different like categories: certain, probable, possible, unlikely, unconditioned, unaccessible, or unclassifiable. And there are different criteria. So there is usually a causality assessment committee will be there, which will be constituted by particularly those who are working in the ADR field, those who are expert. Then in that also some clinicians will be there, some other people will be there, and that causality assessment committee, they will sit together either at the level of ADR monitoring center or at the level of this regulatory center, national regulatory center, and they will establish the causality by a brainstorming session. And there are also different algorithm are available. One is the Naranjo algorithm. There you don't have to do the brainstorming. You have to either yes or no, and you have to award some score. And this is like Naranjo algorithm. But mostly we usually follow this WHO UMC causality assessment. So next is the pharmacovigilance, because as we are aware that pharmacovigilance program is one of the robust program in our country. So we should know what is this pharmacovigilance. Pharmacovigilance is usually defined as the like science and activity related to the detection, assessment, understanding, and prevention of any adverse effect or drug-related safety problem. This is what constitutes pharmacovigilance. Then what are the objective of this pharmacovigilance? To improve the patient care, because ultimately everything is for the patient or patient safety. So it should improve the patient care and safety. It should also improve the public health uh, and safety in relation to use of medicine, because if patient care gets impacted, then in a larger extent it also impact the society. Then it also to contribute to the assessment of the benefit, risks, and effectiveness of the medicine, and encouraging their safe and rational use. Always we need to assess the risk benefit ratio, whether a particular medicine is causing more benefit or causing more harm. If it is causing more harm to a particular patient or a particular patient group or overall, that means we need to discontinue the medicine. If it is causing more benefit, then obviously we need to use the medicine. And all this we are doing so that, because the most important thing is the safe and rational use of medicine to enhance the patient safety. And also another objective is to promote the understanding, education, and training in the pharmacovigilance and its effective communication to the health professional and public at large. Because till now also many healthcare professionals are not aware about the adverse drug reaction, not aware about its impact of adverse drug reaction on the overall healthcare delivery system. So they need not, they don't bother to report, they don't bother to understand about the adverse drug reaction, they don't bother to understand about the pharmacovigilance and pharmacovigilance program. So what is the need of pharmacovigilance? Pharmacovigilance is required because there is a humanitarian concern, because patient safety is the most important thing in the healthcare delivery system, as already I have mentioned. And it is also needed to promote the rational use of medicine and to enhance the medication adherence. Because if patients will develop adverse drug reaction, then he will be scared to take medicine, any medicine. If he is developing some this adverse drug reaction, and if it is a severe adverse drug reaction in future, if someone or if he has been prescribed for some other disease also, he will be very scared to take the medicine, and it will affect the disease process. It will, as already I told, break the confidence. So pharmacovigilance activity is needed to ensure the public confidence on the healthcare delivery system. It is for the promotion of the safe use of medicine. And as already I told, this ADR has a high cost. It increases severely, increases the healthcare cost for the individual patient. It also increases the overall health cost of the society as well as the government. So we need to know more about the pharmacovigilance. We need to know more about the adverse drug reaction so that it can be prevented. So as already I told, The government of India is also running a pharmacovigilance program, and it was launched in 2010. And now this National Coordinating Center is there in that Indian Pharmacopoeia Commission, Ghaziabad. And then there are different advanced drug reaction monitoring center are there in the different hospitals, like all AIMS now. AIMS Bhubaneswar is also Department of Pharmacology is also running this. So ADR monitoring center we have, and many medical colleges, many hospitals are now recognized as ADR monitoring center. And this is the organogram. As already told you that this IPC is usually function as the National Coordination Center for this Pharmacovigilance Program of India. It is situated in Ghaziabad, and there are different ADR monitoring centers. So ADR monitoring centers, they gather the information from the adverse drug reaction from their own hospital, from the nearby hospital, and what is their job? They send it to the uh, this IPC. IPC also get the information from pharmaceutical company regarding the adverse drug reaction of their particular drug. That means from the marketing authorization holder. And then what they do this, they have this different group of expert there. They do the causality, they'll work for the signal generation, and they pass the information to the CDSU for if there is any step to be taken for that particular medicine. They also pass this information to the Uppsala Monitoring Center, which is situated in Sweden, which is the global center of pharmacovigilance, so that all this data from across the globes, from different country can be stored, because we are all related. One medicine company, medicine which has been approved by United States or US FDA one day, that medicine after few years might be available in India, might be approved by our regulatory agency and will be used by our population. So the data has to be shared, information has to be shared to enhance the patient safety. So it has some short-term goal, it has some long-term goal. Like short-term goal are to develop robust pharmacovigilance system in the country, enroll medical colleges, all medical colleges at this ADR monitoring center. Then long-term goal is expand pharmacovigilance to all hospital, not only the medical college or tertiary care center, all hospital, all private hospital. Then to develop and implement e-reporting, to develop reporting culture among the healthcare professional, because this is very essential. Still underreporting is very common in our country, because spontaneous reporting means someone is not compelled to report, although it's kind of a professional obligation, but most people, due to many reasons, they don't report. So underreporting is one of the most common concern. So if we increase the awareness, then there might be increased chances of reporting. So next is the ICR, Individual Case Safety Report. What is this ICR? ICSR is a document in a specific format for the reporting of one or several suspected adverse drug reaction to a medical product that occur in a single patient at a specific point of time. So ICSR is very important, because this is what we are reporting. So this ICSR should contain minimum four basic element to be considered it as valid, reportable. That means to be considered it as reportable. So what it should contain? It should contain information, that means about the patient, identifiable patient or subject who has developed this adverse drug reaction. Identifiable reporter, that means someone has reported it, whether it is a healthcare professional, doctor or nurses or pharmacist. So it should have an identifiable reporter, details about the reporter. And a suspected drug, that means detail or information about the suspected drug which caused this suspected adverse drug reaction. Then it should also contain information about that suspected adverse reaction or event. That means when it has started, whether it has stopped, what type of reaction it is, all those things. And there is a timeline, particularly for the marketing authorization holder. There should be a timeline for the reporting. If it is a serious ADR, it should be reported within 15 calendar days. If it is a non-serious type, it should be reported within 90 calendar days. And this is what about our suspected adverse drug reaction reporting form. It is what provided by Indian Pharmacopoeia Commission. It is available in their, that means CDSO, in their website. And here, if you see, or if you can go to their website, you can also download and you see what are the different type of information available. What I told you, that it should contain this information about the patient, information about the drug, information about the suspected adverse drug reactions, and information or detailed information about the reporter. So here, if my suggestion would be to go to the IPC website and download this adverse drug reaction reporting form and see, because this is what we are using in our ADR monitoring center. Whenever we are getting information from any department or any this thing, any ward, that okay, we are have this patient had developed this sign and symptom, and we are suspecting it could be a adverse drug reaction. If clinician report, then we either our postgraduate student or our pharmacovigilance associate or a coordinator, we go, we take this adverse drug reaction reporting form, and we take all those necessary information. We come back, we sometimes do the causality assessment at our own level, and also we pass this information to the this national coordinating center situated at the IPC Ghaziabad, to this software. Then question might come to our mind. Okay, we are talking about adverse drug reaction. We are talking, and we need to report it, because spontaneous reporting is the very important mechanism, because this from this spontaneous reporting only we can get many of the data or many of the adverse drug reaction. So if a clinician or any other person might ask, we need to know some of the basic information. Like what information? What to report? What kind of reaction can be reported? Who can report? Can I report it? Shall I report it? And if I can report it, where to report? So all these things we need to know. It is also mentioned in that adverse drug reaction reporting form. If you go and check that backside. So what to report? According to the IPC, we can report any serious drug adverse drug reaction. We can also report any adverse drug reaction, non-serious, known or unknown, frequent or rare adverse drug reaction, either to a medicine, or it can be reported if it is occurring due to any herbal product. It can also be reported if it is happening with the vaccine. There is this adverse event following immunization, AFI vaccine, AFI program is also running in our country. So we can report whether it is occurring with our this conventional medicines or with the indigenous drugs, or can be with the medicines. Nowadays also there is, although that is a separate program, we can also report the adverse event which is occurring with the use of medical device, and that is known as metro vigilance program. So who can report? All healthcare professional, whether it is a doctor, whether it is a nursing professional or the pharmacist, anyone can report it. Where to report? It is either we can report it to the nearest AMC, like if someone has suspected any adverse drug reaction, either it can be informed to the nearest AMC, or if a particular person or particular healthcare professional, he is aware, he is skillful, he knows how to fill this ADR reporting form, he can fill it by himself and report to the, or send it to the nearest AMC, or it can be sent direct to the National Coordinating Center at IPC Ghaziabad. And there are also toll-free helpline are there. We can contact this IPC through that, or we can also directly mail to them. And as already I told you, spontaneous reporting system is very important, because this reporting is the meaning of spontaneous reporting means reporting of any suspected ADR by any healthcare professional. Again, I am emphasizing, although it is not mandatory, not compulsory to report any ADR by any healthcare professional, it's kind of our professional obligation to report ADR, so that we can enhance the patient safety. We can promote the safe and rational use of medicine. It is voluntary, it is unpaid, and it is, as already I told, it is most common method of reporting. Periodic safety update report is kind of a document. And it is has to be filed by a marketing authorization holder at regular interval. and it's a comprehensive documents. I will not go into the detail. So what the frequency is that 6 monthly, it has to be report in a 6 month interval for in the first 2 years of getting approval for a particular drug, then yearly for the next year. Then that pharmaceutical company or marketing authorization holder has to report as and when asked by the has to submit this PSUR as and when asked by the regulatory agency. So all of us together we can promote the safe and rational use of medicine if we promote the pharmacovigilance, if we can promote the adverse drug reaction reporting, if we can enhance or if we can increase the awareness about the adverse drug reaction reporting among at least among the healthcare professional, if can do it among the consumer or among the patient, then also it is very good. So with that I conclude my
Sir,
talk.
thank you for that elaborate presentation, and for so much of time you have taken to enhance our knowledge, and of course the audience regarding adverse drug reactions. One quick question, and then before we close, is it one of this participant has asked? Is it possible to develop ADR to a certain medication because of the excipients inactive ingredients rather than usual active drug in its composition, rendering the patient allergic to the drug as a whole? If something can be replied to this before we close.
Yes. ADR can occur either due to the active ingredients or it can occur to the inactive ingredient. Like I told you, I given that example, famous example, where that sulfanilamide, usually it was not causing that. It was causing because we added something else, this diethyl glycol. The diethyl glycol was not treating the infection. It was only used because it has to be converted into a elixir or liquid form. And that only, that drug itself or active ingredient did not cause any death. That rather than that, other things, diethyl glycol was responsible for that death. So definitely this adverse drug reaction can occur either due to the inactive active ingredients or also can occur due to the inactive ingredients. Thank you.
Right, sir. Right, sir. So next we have the next webinar is on 18th of December on medication errors by James Batinda. So thank you once again to the esteemed speaker, Professor Bikas Ranjan sir. Thank you so much.
Thank you. Thank you.